Hello, everyone. We've now learned of various different approaches to mitral valve disease. Among the most common pathologies facing the human condition is aortic valve disease. Previously, that has traditionally been approached by a sternotomy approach to do surgical aortic valve replacement, which involves opening the aorta, taking out the valve, and replacing it with a prosthesis. Recently, transcatheter aortic valve replacement has been another alternative. However, there's still many patients where transcatheter therapies may or may not be appropriate. But people want a non-sternotomy option. There are many direct vision approaches through a variety of incisions in the chest, usually anterior or the side or the front, just direct vision, or using a video scope. I'm really happy to share with you our development of a technique of transaxillary robotic aortic valve replacement, or RAVR. What we're going to walk through is how this was developed, why it was developed, and the unique aspects of performing and learning how to develop expertise in launching robotic aortic valve replacement in your program.
Now, we're very pleased to share with you a procedure known as the right lateral transaxillary robotic aortic valve replacement, or what we've called RAVR. Now, surgical aortic valve replacement, or SAVR, and transcatheter aortic valve replacement, or TAVR, are options for patients, but this procedure is not performed through a sternotomy, obviously robotic, as we've been talking about, through the exact same platform or incision we have just demonstrated for mitral operations, except the approach now is for the aortic valve. So let's begin. We'll now walk through the fundamental steps of performing a RAVR. The first is the setup, and we've demonstrated previously that the mitral location for the aortic root vent is more anterior. The RAVR location for the root vent or aortic valve is more lateral. So here we see the suture placement through the working incision for the aortic root vent. And this is a pledgeted using 4O polypropylene to deliver a long aortic cardioplegic catheter. And the mitrals are placed anterior and across the chest. The RAVRs are placed lateral and through the working port. Now, this is an important point. We have developed a small technique called the right atrial retraction stitch that we've done here at WVU by placing a pledgeted stitch through the trapdoor pericardium and then tapping the central tendon of the diaphragm and bringing it back up and then out through the vent, LV vent port that we placed. This is obviously a double loaded, so a pledgeted stitch, and as you can see, we avoid the phrenic, but allows for increased exposure of the aortic root. So this is a patient who presented with severe aortic regurgitation. The patient was approximately 75 years old, who had LV dysfunction and not a candidate for transcatheter therapy. Plus, he was very robust and active, but highly symptomatic with LV dysfunction. We can see the severity of the aortic insufficiency there. But also, the patient had aortic sclerosis and annular calcification. With severe aortic insufficiency, we felt that sternotomy aortic valve repair may not be the most ideal. Ascending aorta is then cross-clamped, and now we see we start to expose and incise the ascending aorta. Initially, in a very conventional way, we identify the valve in the left main, and then we take this down tangentially and down in an oblique manner to the sinotubular junction of the non. We arrest the heart using coronary ostial cardioplegic catheters, and this provides direct coronary ostial cardioplegic protection to arrest the heart. And then you can see very clearly superb exposure of the valve. We've incorporated the long tip forceps you can see at the top right of the screen, which is a different instrument for cardiac surgeons, but commonly identified in the gynecologic and general surgical OR. The leaflets are excised. Now, this is important. We have to always make sure we completely debride the annulus and of all calcium. We incorporate a suction aspiration device that is coming in the field here that we can then aspirate as we go to ensure we have a thorough debridement of the annulus. This is very important as we have a thorough operative procedure. You can see the optical precision to be able to see all aspects. The valve is then excised, and we have a approach. We then remove any and all morsel of calcium completely and thoroughly and irrigate. Now, these sutures are placed. These are these 4 needles on a braided stitch of 2/0 caliber. It starts at the non-left commissural post and extending circumferentially, very similar as we would do in an open case. We can see the left-right commissural post now being approached. Now, what's different at this juncture, once we have approached the commissure on the left side, these remain coming out inferolaterally. We will demonstrate this in a future video. But once you hit the commissure, we bring that suture anteriorly, as we demonstrate here. Continue doing this circumferentially. Now, this is a technical point that I prefer that when we go about noon on the clock face or in the midpoint of the right coronary sinus or the right-facing leaflet, I switch to using the DeBakey in the left hand or the number 1 port to enable suture placement and keeping things coaxially with the camera central and the sutures being placed on the outside. As you can see, as we approach the right non-commissure, we can really clearly see the membranous septum. And by so avoiding this region and using non-pleated sutures, this may explain the pacemaker rate from RAVR being less than 2% globally and less than 1% in our institution due to the precision of suture placement and visualization. Here we are rounding the non with the final sutures being placed. We then meticulously irrigate the entire field to ensure complete removal of any and all particulate matter. We incorporate the sizers. We've received FDA approval to adjust them as you see here. And then we give corneosteal catheters back in while we place the sutures extracorporeally, deliver the valve through the working incision, and we can see this is a 25 millimeter bovine bioprosthesis. This is important. We're delivering the valve in a very careful way to protect the aortotomy. I call it parallel parking in that we bring the left-right post first, followed by the rest. And now we have it nicely seated. We confirm its appropriate seating. And then we proceed to work in unison with your tableside surgeon or associate. In this case, this is my close partner, Dr. Lawrence Way. And we place the suture fasteners. Now, we prefer to put the nadirs first, and this is just for anchoring the prosthesis for stability. But for another reason, which we're going to demonstrate in just a moment, but this is most important to show that we're working together to expose, to keep the suture fastener device coaxial. Now, this is why we grab the suture fastener, and now between the posts, very gently on the posts, and the suture fasteners, we walk in a stepwise fashion, moving the valve ever so slightly to allow the suture fastener to be delivered in a straight way. This is important because then allows the sutures to be placed cleanly and flush with the prosthesis sewing ring, as well as safely. Now, here is our completed RAVR. And now we approach this, we double check, make sure that the valve is well seated, do some completion irrigation, and then proceed to close the aortotomy. I've inserted a catheter device in the left main just to give some cold blood while we do this. This is a 2-layer using fluoropolypropylene, using a pledget at the anchor points. Of course, the surgeon's preference can do either 1 layer or no pledgets, but we find that this is a very standardized way and also very safe way, particularly as we increase complexity. So the first anchor suture is placed. I usually prefer to go through the pledget with the second bite. And again, the first layer is a horizontal mattress in order to bring together the tissues in a very safe way. As patients get older, the aortotomy can be a little more treacherous because of the calcium of the aorta. And all experienced surgeons around the world know this and can navigate this very carefully, equally as you would do through a sternotomy, and do this robotically. So this completes the first horizontal mattress layer. And then we then go back using the long tip forceps to do some slight distraction to really get a great exposure of the base of the root, as you can see. And then with a combination of backhand and forehand sutures, make this superficial or top layer as a running suture. And then do the same element by completing a 2-layer closure from medial to the midpoint. And this completes the aortotomy closure. This takes approximately 20 minutes to do safely. It might take longer for more complex aortotomies, but our plateau is around 18 to 20 minutes. So this is the final suture. We place this. Following this, we give antegrade to not only test the valve, but also make sure our aortotomy is intact and without any bleeding whatsoever. We place pacer wires epicardially and then reanimate the patient and wean from cardiopulmonary bypass. And here we see the intact and nicely functioning aortic valve with improved ventricular function with offloading a mean gradient of 8. Now, the vast majority of our patients are extubated in the operating room, and with the express permission from our excellent patient, this is him walking 4 hours postoperatively. So we would submit to you that this is the result that we can achieve robotically as it compares to transcatheter or other surgical approaches to aortic valve replacement.
So now we've seen the fundamental principles of performing RAVR. One of the important aspects of all robotic surgery, but particularly RAVR, is not just the console surgeon, but also the tableside surgeon or the tableside assistant. So join us in the next episode where we're going to do a choreography side by side of how we assist in the performance of RAVR at the tableside. At the same time, we're performing it at the console.